Welcome to the Black Belt Nurse Podcast, where we discuss all things related to violence in healthcare. I'm Bill Schuler, your host, and this is the place where we learn together, mull things over, and generally figure things out. Whether you're a seasoned expert, a student, or just passionate about safety in healthcare, this is the podcast for you. Before we dive in, a quick disclaimer. We do discuss all aspects of violence in healthcare, some of which may be inappropriate for younger listeners and viewers. Please use discretion. The Black Belt Nurse Podcast is for informational and educational purposes only. While we discuss experiences, strategies, and science, this podcast does not provide medical, legal, or professional advice. Always consult your healthcare institution's policies and guidelines or seek professional advice when necessary. And of course, all opinions expressed here are my own and do not represent any employer or organization. Now, let's get started. Hello, everybody. In this episode, we're going to attempt to answer the question, is violence part of the job? What we're going to look at is a recent study that asked that same question. The name of the study is Nurses' Perceptions and Expectations of Patient Violence, Language Matters, and this is by Darcy et al., and this was published in early 2025. I'm going to set this up from what they state in their introduction. Quote, based on the available data, it is evident that nurses in hospital settings are exposed to patient violence at disturbingly high rates and frequencies. At the same time, there are workplace violence prevention campaigns purporting that violence is not part of the job. There exists a potential contradiction between the lived experience of many nurses and the language in some campaigns addressing violence against nurses. It seems contradictory to state that violence is not part of nursing when 1/4 of nurses report having been assaulted while at work. There are also workplace violence prevention campaigns that utilize slightly different language to indicate that violence should not be a part of the job. The shift in language from is not to should not is important. The former identifies a descriptive state intended to reflect reality. The latter refers to a desired or ideal state. It is important to accurately distinguish what nurses are experiencing from what nurses ought to experience with respect to occupational risk. In the present case, patient violence. Utilizing clear and accurate language is not a matter of splitting hairs. Different words carry different meanings and evoke different responses. Available statistics indicate that patient violence is, in fact, a part of many nurses' jobs. Whether it ought to be is a different issue. So this is the premise for their study. Now, it's a pretty descriptive study. They had almost 500 people participate in this from over 3,000 that they sent surveys to. Of course, the vast majority were female nurses, about 75%, and about 7% were male. Now, they asked 3 questions that I feel are pretty important to look into and dig deeper into what these mean, not only how the nurses answered the question, but also what they wrote in comments after the questions. Now, before I get into that, let's break down where these nurses are from so we can get their perspective a little bit. So you've got about 19% are from acute care. You've got 14% in ICU, 14% from the emergency department, and 17% which didn't really respond to which area they were coming from. Now you look at the type of nurses, the vast majority are staff nurses at 68%, 7% of them are from management, and about 17% really did not respond to that question. The first question, do you think it is possible to prevent patient violence in acute care facilities or hospitals and get to 0 instances of patient violence? So that's question 1. Question 2, do nurses in acute care facilities expect to be exposed to patient violence while at work? And question 3, should nurses in acute care facilities expect to be exposed to patient violence while at work? Let's address question 1 first. Do you think it is possible to prevent patient violence in hospitals and get to 0 instances of patient violence? The percentage of people who answered yes to that is only 15%, 1-5. The people who answered no is 85%. So 85% of these nurses that responded to this survey do not think that it is possible to prevent patient violence and get to zero incidents of violence. Some themes that were in the free text after the question. So let's look at question 1. Do you think it's possible to prevent patient violence and get to zero incidents of violence? The people who answered yes to that, this is kind of what they put in their narratives. They need better mental health treatment. There should be more leadership support, including staffing and security. There should be staff training and behavior. There should be early intervention. Patients should be able to control their behavior better, and there should be accountability for behavior. So that's the people who answered yes. Those who answered no say this: we need better mental health treatment. The patients are human. They're sick. They're hospitalized. Some patients choose to be violent, and we can't prevent it, but we can mitigate it. So those are some of the common responses to question number 1. Now, question number 2, do nurses in acute care facilities expect to be exposed to patient violence while at work? Do they expect it? 81% of them said yes. 19% said no. More on the themes of what they wrote after the question. Those that said yes say it's a normal part of the job. It's the nature of the work. There's a rise of mental health issues and lack of mental health resources. There's customer service culture, and there can be the expectation that it's going to happen, but not acceptance that it's happening. So that's 81% who said yes. The 19% who said no had this to say: you could expect that it's a possibility, but we want to be safe at work. Some of us don't anticipate it, and we are really here to provide care. All which is true. But that's the people who said no, the 19% who said no. The third question: should nurses in hospitals expect to be exposed to violence while at work? 32% said no, 68% said yes. Here's what they also had to say. Those who said yes, hey, it's because they're patients. They have altered mental status, mental health needs. It is a reality. Kind of highlights that, well, we shouldn't expect it, but does it happen? Yes. Now, let's look at some other statistics as we get into asking and answering that question. Is violence part of the job? Well, let's look at some Bureau of Labor statistics, workplace violence incidents involving days away from work, and the incidence rates is per 10,000 full-time workers. So just remember that it's days away from work, meaning that an injury is severe enough that it requires some time off of work. So when we just look at violence, in 2020, the rate was 4, and in the next set of data, it's 6.2. So that was a 55% increase from 2020 to the biennial 2021-2022. So that's all occupations, just in general. Now, when we break it down a little bit, nursing assistants, orderlies, and psychiatric aides. 2020, it was 55. The next was 80.9. So that is a 47% increase, and that is 13 times the injury or incidents than all occupations put together. For RNs, it used to be 18.2. Now it's 25.2. That's a 38.5% increase, and that is 4 times all the other occupations. When you look at healthcare diagnosing and treating practitioners, they changed that category. So we don't have the comparison data to 2020. Their rate is 15.2, which is 2.5 times all other occupations. Now, when you dig into the workplace violence data and you get a little bit more specific into intentional injury, then for all occupations in the private sector, that rate was 2.1. Now it's 2.9. That's a 38% increase. For nursing assistants, orderlies, and psychiatric aides, it was 41. Now it's 55.6. That is a 35.6% increase, and that is 19.2 times all other occupations. For RNs, it was 14.2. Now it's 17.8. That's 25.3% or 6.1 times all other occupations. And when you get into the healthcare diagnosing and treating practitioners, it's 9.9, which is 3.4 times. So healthcare, compared to all other occupations, suffers a good majority of the injuries involving time away from work. Now, they also had statistics on the median. Remember, that's the middle. You have a range. The median is the middle of days away from work. So for all occupations after a workplace violence event, it typically tended to be 12 days. For RNs, it used to be 13. Now it's 11. And for nursing assistants, orderlies, and psychiatric aides, it used to be 12. Now it's 10. So maybe the severity of the injury seems to be decreasing over that time frame. You got 2020 data to 2021 and 22 data. A lot of workplace violence doesn't result in injuries requiring days away from work. So this is only catching the high level ones that actually require some days away from work. If you look at the trend of intentional injuries from workplace violence, it's been climbing. If you look at the Bureau of Labor Statistics graph, it's been climbing since about 2011 with a more sharp increase since 2018. Their data only goes up to 2020, but we know what happened in 2020, the pandemic. In 2022, Press Ganey put out a statistic that an average of 57 nurses are assaulted every day and 2 nurses are attacked every hour. The Emergency Nurses Association did their own study that they published in April of 2024, and they said about 56% of ED nurses were assaulted in the past month. National Nurses United did a study of some of their members. They had over 900 respond and had experienced at least one type of workplace violence in 2023 alone. That was 81.6%. Over 2/3 were verbally threatened. Almost 40% were physically threatened, and about 30% were physically harmed. And it ranges from being pinched or scratched to slapped, punched, or kicked. And this is in the order of numbers: objects thrown, verbally harassed based on sex or appearance. They were spat on or exposed to other body fluids. They were groped or touched inappropriately. And that was 20%. That's significant. And slightly less than 20% said that they had not experienced any workplace violence whatsoever. A little bit more on this. What was the impact of that workplace violence on them? Over 2/3 said they experienced some anxiety, some fear, or increased vigilance. They considered leaving the profession. They actually had some sort of physical injury or other physical symptoms. They had difficulty working in the environment that reminds them of the past incident. They took some time off of work. Slightly less than 20% changed or left their job. About 10% had psychological effects that prevented them from working. A few, just 4.1%, left the profession altogether. So we cannot say that it does not affect the profession of nursing. Now let's get into reasons for violence. And some of this is highlighted in this study, which we'll go through later on. This is what is found in the literature. So medical reasons for violence. We have quite a list here. It could range from trauma, and that could be from major body systems to head trauma to thoracic trauma, where it affects your ability to breathe and oxygenate. So that's, that maybe is one aspect. You've got hypoglycemia, which is low blood sugar. You could get it from hyperglycemia as well. You can get it from hypovolemia, meaning that you don't have enough blood or enough blood pumping into your body to get that oxygen to your tissues and to your brain. You've got hemorrhage. You've just got bleeding, just in general. You've got hepatic failure or liver failure. That could be hepatic encephalopathy, where your liver isn't working quite well and not being able to get rid of all those waste products, and they're building up in your blood. They're affecting how you are able to think and act. You've got acute intoxication. That could be from alcohol. That could be from any type of other drug that is affecting your ability to think rationally or soberly. For those of us who have worked with intoxicated individuals, you get your happy drunks and you get your not so happy drunks. You could have a medication reaction. You can get agitated from taking certain medications, such as steroids. You can have side effects from medications. You can have hypoxemia, where you're having low oxygen in your blood, low oxygen to your brain. It could be from seizures or coming out of a seizure where you're not quite back to normal. It could be hypothermia. It could be hyperthermia. Your temperature is too low. Your temperature is too high. It could be meningitis, an infection in the lining around your brain or around your spinal cord. It could be encephalitis, inflammation around in the brain. It could be sepsis, meaning that you have an infection that your body is trying to fight off. That can be fairly severe. It could be shock from many different things. Shock from trauma, shock from an infection, shock from your heart not pumping appropriately. It could also include being in acute psychosis, meaning that you are in a psychotic state. You're not thinking rationally. It could be a new diagnosis. It could be not taking medications as they should. It could be going off medications. Many different reasons for acute psychosis state. It could be a crisis state where you are in a crisis and it's overwhelming your ability to cope. It could be decompensated mental illness. Again, that could come from medication or lack of medication or just a new diagnosis. It could be also from coming out of anesthesia. Some people can be acutely agitated or even violent when they're emerging out of anesthesia. So those are quite a few of the medical reasons why people can be violent. Now, there's quite a few non-medical reasons why people can be violent, and that can range from ED crowding, where the emergency department is full. You have patients that are boarding in the emergency department, meaning that they're staying there. The nurses are having to take care of them because there's no room or they need to go on the floor to the ICU, to med surg. So it's taking up bed space. The definition of emergency care is episodic care, meaning that we would treat, stabilize, and transfer them to where they need to go, or they will get discharged and leave the hospital that way. You have increased wait times, and that's where ED crowding and ED boarding kind of has this additive effect where people expect to be seen and be treated in a timely manner, and they aren't, and that can increase agitation. There could be poor staffing or lack of staffing, which, bogs everything down. We know that we're not able to pay attention to our patients when there's not enough staff. We even know that we miss signs of people, patients or even visitors and family, that they increase their agitation. And sometimes we're so busy, we're so task focused that we miss the signs of them escalating. We also have patients that we just don't know anything about. We don't know their history. We don't know if they've been violent before, or maybe we do, and we don't communicate that because we don't have flagging processes in our chart. We have no way of communicating, or we just are bad at communicating, or we even don't consider that part of the patient's medical history or kind of as a safety communication. We know that gang activity can make its way into the hospital. We know that domestic violence can make its way into the hospital. We know just hospitals being open to the public, unrestricted hospital access, where there's many entrances and exits to the hospital. They're not being monitored. They're not being controlled. We're not funneling people into a couple entrances where we can also do some weapons detection. That increases the risk as well. There's presence of firearms or weapons. If you think that there's no weapons floating around a hospital, you will be surprised. Every place I know that institutes a weapons detection system, and that could be metal detectors, it's amazing what they find. Most of what they'll find are knives. You might find a gun or two here and there, but there's plenty of weapons on people. And if you're not checking, they're making their way into your hospital. Now, is most of violence in the hospital happening from a weapon? No, it's mostly happening from being kicked, spat on, punched, grabbed, pinched, bitten, all that. That's most of what the violence in hospitals is. You could have poor lighting. You could have just poor environmental design where there's a lack of lighting in your parking structure or your garage or even certain parts of the building. You could have people who are working alone. You could have a lack of a duress or a panic alarm that can get you help in a timely manner. In some of my experience, you do have duress or panic alarms, but they don't work when you need them. Or as I've heard from other people, people aren't wearing them. You have a lack of easy escape route, like there's only one exit and entrance to a room so that you could get back into a corner and there's no escape. Or you're fighting to get through the door, somebody's pulling you back into the room, or just like even how the door swings. Does it swing out? Does it swing in? Do you have to pull yourself back into the room to get out of the room? Or does the door swing both ways? Or is it a sliding door? Does it have a breakaway where you can easily, break out of it? And inefficient ED throughput, that kind of goes into crowding. We're expected to bring people in and get them out in a timely manner so it keeps flowing, but there's always, especially nowadays, there's crowding. You have inadequate security presence. You have no security. Or let's say you put your facilities person and their security. Are they trained? Maybe, maybe not. Or maybe your security staff are not adequately trained. Are they trained in de-escalation? Are they trained in citizen's arrest? Are they trained in the rules of the state or the law? Do they know federal law? Do they know, what can precipitate workplace violence? Do they know how to properly restrain patients or people? I've even heard of this person is too violent for jail, and then they bring them to the emergency department. There's patients that are brought in by law enforcement for a medical clearance, which can, if they're violent on the street, there's a likelihood that they could be violent in the emergency department. You have law enforcement who have more tools than hospital security, definitely more tools than nurses do. And here they're being brought into the hospital setting. There could be just a lack of a procedure or a policy. What do we do when this happens? What do we do after a workplace violence event happens and somebody's injured? Where does that caregiver go? How do they get care? How do we contact them? Can a manager or a supervisor submit the workplace violence report on behalf of the nurse? Did you think this through? And do you have a plan? There could be a lack of mental health personnel. Of course, we have a crisis for mental health treatment just in society in general. We don't have enough resources. And so that kind of spills into our hospitals. And then being told no and even reacting to bad news. That can also be an antecedent to having some form of workplace violence. That's a wrap for this episode of the Black Belt Nurse Podcast. If you enjoyed this episode, don't forget to like, subscribe, and hit that notification bell so you never miss a new episode. Drop a comment below and let me know your biggest takeaway. I would love to hear from you. You can find me on LinkedIn and Facebook, as well as blackbeltnurse.com. For now, be safe, and I'll see you in the next episode.